În continuare, aș dori să o rog pe doamna profesor Jessie Pavlinac să prezinte câteva informații interesante din experiența dânsei. Este fost președinte al Academiei de Nutriție și Dietetică și în aceeași măsură este și, deci predă și mai multe discipline ceea ce privește nutriția și dietetică la o facultate din Oregon. Are, după cum v-ați dat seama dimineața, foarte multă experiență în domeniu. Please allow me to introduce Ms. Pavlinac. I don't know. Is your presentation this one? This is, I wasn't sure.
Good afternoon. Is everybody cool and ready to sit here for another hour? No, but we're going to anyway. So thank you so much for inviting me here. I love coming to Europe because you treat people fabulously, and Romania has done, our host from Romania has done this country proud. So thank you very much for having me. Nope, wrong way. So today I'm going to spend about a half an hour talking about the nutrition care process and model and the international dietetics and nutrition terminology. And that was spoken about by Marcia earlier because it has been, it is international, and several the countries have participated and have actually translated that document. And one of those books, yeah, right there. One of those books was part of Dr. Dan's gifts, so you'll be able to look at it. Okay, we have the pocket guide. There we go. The current edition is the 3rd edition, and we will have a new edition out this fall. And so we continue to evolve the language of dietetics. Our challenge in whether we're in Europe, Asia, Canada, United States, the whole entire world, is we use words differently. And they don't always mean the same thing. Marcia spoke eloquently about how difficult it is to come to consensus about what a word might mean to all of us. And so in order for us to really be recognized as a valid profession, we need to have the language that we all use so everybody understands it and our colleagues in healthcare understand it. Went the wrong way. So the key message today is that nutrition care process and standardized language will take dietetics to a new level of performance and recognition. So why do we need a nutrition care process and model, or even a standardized language? It's because of that, and we'll go through some of the answers about that. And then I'll briefly go through the model components and the steps of the model. And this model has been around now for about 8 years, 7, 8 years, yeah. And in the United States, we knew it would take time for adoption. We gave ourselves 10 years to have it fully adopted. In practice, it is less adopted than it is in education, because we knew that if we required knowing the model and the process and the language in education, that would move quickly into practice, and then we would be able to implement it throughout the whole country. So it has been tested. We do a 4-year program, and then either the supervised practice within that 4 years or additional, which I'll talk a little bit about tomorrow. And then we do a national exam. And so we have questions about it, so students have to know it in order to become registered and ultimately licensed if that's what is the case in their state. So again, why is it important? The role of dietitians have always been to provide food to institutionalized patients, at least in the United States. That's where it started out. And then nutrition assessment and the clinical piece in the United States did not really take hold until the 1970s. So our association started in 1917, so it took to the 1970s to really have a presence and be part of the medical care team. And that was quite some time. It is also, we've been doing nutrition education and providing information to clients and consumers for a lot of time. And we've always documented that we were making a difference to patients. Documentation, at least in the United States and every other country also, is the key for others to know what you're doing, right? It's also the key to show that what you have done can be looked at, so you can look at that you made a difference in the patients. Because why would anybody allow us to be a profession if we didn't make a difference? So documentation is key, and again, that's where standardized language and a process comes through. So the nutrition care process moves us to a higher status where we, our own profession, determine which nutrition problem we need to address, versus just responding to what another profession, mostly at least in the United States, a physician has already identified. In the United States, most physicians may get one course in nutrition, and a small number of them have specialized in nutrition. I work with an excellent one at my facility, but many of them have not had much training in nutrition or even an interest. And sometimes the diet that they've chosen that they think their patient might need, there's really no evidence for it. And so that's why we need to make sure we have evidence, as all of us have said. It also provides, as I said, a common language to name the nutrition problem, to give it the same name whether you're in Romania, California, USA, the United Kingdom, Canada, Hong Kong, throughout the world. And that problem is the nutrition diagnosis. It's structured documentation to link the assessment data, which are the signs and symptoms, to a problem, and then an intervention and etiology of the problem. And so we use a process called the PES statement, which is problem, etiology, and signs and symptoms. It is also important because it identifies signs and symptoms expected to change based on our intervention, not the rest of the healthcare team, even though we know that we're all integrated and we need to do things cooperatively and not against one another in order to intervene with the patient. The notes that we would chart in the record of their care would clearly state the problem and show some improvement according to our plan. And as I said, it positions the dietetic profession in a global economy in both education and credentialing. So standardized language is intended to be the agreed upon terms that will describe what is occurring in each step of the process, which I'm going to go through next, which is the assessment, diagnosis, intervention, and then monitoring and evaluation. And it's a continuous circle. Then you go back and reassess. Perhaps the diagnosis has changed or gone away, or a new one has occurred. Nutrition intervention terms, what you might do again, and then monitoring and evaluation. So it really is a dietetics dictionary, and as we move to more electronic health records around the country, if we have the same terminology, then we will be able to globally look at patient treatments, look at specific diagnosis in our interventions, and see what works best and what doesn't work best. A fabulous opportunity for practice-based research. So these are the publications. This is the most, well, these colors aren't true, but this is the third edition, and the one over here was the original one. And Karen, what color is the new one going to be? Do you know? I don't know either. We change colors to keep them straight because it's hard. Oh, there's more of them, sorry. The nutrition care process has 4 distinct but interrelated and connected steps, and some supporting systems also. So, has everyone seen this diagram? Anybody seen this diagram? Oh, couple, okay. Then I was afraid that you might have seen it. You're going to see this multiple times because every time I show it, it'll have a new arrow showing where I'm at. But essentially, that piece up there is a referral or a screening system. You have to figure out which of the clients or patients you're seeing need your intervention, because not all of them do. And that's where that first comes in. We're not going to spend much time on that, though. The core components are the core of this diagram. In the center, we're going to go from the middle to the outer rings. The core is the patient or the client and how that patient interacts, or the rapport that they would have with the practitioner or the dietitian. We do know that the success of our intervention is our bedside manner, so to speak, because we need to connect with the individual. The outer circles are in the environment in which we practice, so our practice setting, whether it's a hospital or in a clinic or in school lunch, etc. Then you have healthcare systems, the economics of what's going on within your country or within your local environment, and the social system. You know, in different countries, how the family will be, needs to be involved with the patient care, and how they interact needs to be really considered, otherwise you're not going to be successful. The outer circles are what the dietitian contributes, which is collaboration with the other healthcare professionals, communication, evidence-based practice, code of ethics, critical thinking. So you gather data, you have knowledge and skills, and how do you take that data and transfer it into a plan, and skills and competency, and then of course our knowledge. Medical nutrition therapy is a term that we use in the United States. It's actually a legal one that we have a definition for, and it implies individualized nutrition assessment and treatment as part of the overall healthcare treatment process. It requires a dietitian to document in the medical record. Nutrition education may follow the nutrition care process, but not raised to the level of treatment, or it might. So a very complicated nutrition intervention, such as with renal disease, where you're modifying, sodium, potassium, phosphorus, fluids, perhaps protein, certainly raises to that level. Oh, and not all activities we do as a profession really are through the nutrition care process. Consultations with our colleagues in other disciplines is really not part of that process. It reinforces what we can bring to the team, and it may not be specific to a patient, for example. Screening, I'm going to go by that. The nutrition care process begins when you see a patient or client, and you have identified, through whatever criteria you've established through evidence-based information, those that are at nutrition risk and needs further assistance to achieve or maintain nutrition goals. And it ends only when nutrition goals are met. Oh, goodness. The assessment is to obtain adequate information in order to identify that one nutrition-related problem, or in many cases, multiple problems. Oftentimes, an individual will have diabetes, cardiovascular disease, renal disease, and you may have to do some intervention around all of those. But maybe that patient isn't ready for the magnitude of change that they may have to make with all of those, and you have to figure out what the most important to work on first and then move on. It is a systematic process of obtaining, verifying, and interpreting the data. In the model that we've developed, there are several large domains. Food and nutrition related outcomes, we have 8 categories and 170 terms within that. None of us can remember them all, and that's why we have those pocket guides. Anthropometric measurements, height, weight, what you might gather. Biochemical data, so the laboratory data. There's 13 categories there and 120 terms. Nutrition-related physical signs and symptoms, whether it is fat loss or muscle loss, client history, and comparative standards. And those comparative standards are energy needs. What are you using to base your energy needs on? We all know there are many formulas out there, and some of them are appropriate for certain patients based on what the literature has shown. Micronutrient needs such as protein, calories, and protein, carbohydrate, and fat, fluid needs, micronutrient needs, vitamins and minerals, weight and growth recommendations for children. And that data, you include data that is unique and contributed by dietitians. And I've been in practice for over 30 years, okay? I'm now a manager of dietitians, but I also still see patients. Dietitians, at least in the United States, like to know every bit of information about the patient and write it all down. Hard to break that. But we can ask Dr. Dan if he's reading those notes from the dietitians that would be 3 pages long. He's smiling, no. And we don't need to justify, if we are truly a profession, why we're saying this by every little piece of data when everybody else has looked at that data too. We are bringing our own professional expertise, looking at the data through that lens of nutrition and dietetics, and then making our recommendations. Includes data created by others, but used by dietitians. So we don't draw blood. In diabetes, we may do some point of care or some finger stip in the States, depending on what your practice is. We don't draw it, so we're using data that others have gotten, or we collect our own data through physical exam, or looking at the patient, or feeling their hair. The nutrition problem or diagnosis is the identification and labeling of what that problem is. And we have 3 domains. And this has been the newest concept for the dietetics profession, and probably over nationally trying to get that concept being comfortable with professionals and integrated into their practice. And I do know in my own setting, dietitians have thought as diagnoses as being totally in the purview of a physician. And certainly medical diagnoses are in the purview of a physician. But the definition of a diagnosis is the act of identifying a disease or a condition from its signs and symptoms. And it's in the investigation or analysis of the cause or nature of the condition, situation, or problem. And it implies some predefined list of potential conditions, which we have done in the nutrition standardized language, and some predefined criteria, signs and symptoms, which they can be compared to. So medical is usually only by physicians, and it may be acute or chronic. Nutrition diagnosis can be made by the dietitian professional. It's within the context of the medical diagnosis. For an example, a patient has type 1 diabetes. We're not diagnosing the diabetes, but through our talking to the patient, looking at the data, what we might be diagnosing, that they have they're not doing the right kind of carbohydrate or the proportion of carbohydrate within their whole meal plan, and so it's an imbalance of macronutrients perhaps. Or we're not defining or diagnosing chronic renal disease, but we can look at the data of an elevated potassium and have listened to what the patient has eaten and can say that they have a too high of intake of the mineral potassium in their diet. So that's what we mean. It's in the context of a medical diagnosis, but it really is our own because we have the information about why that might have caused it through nutrition and dietetics. And many nutrition diagnoses aren't chronic. So somebody will have diabetes for their life, unless they get a pancreas transplant. But perhaps through our education and intervention, their ability to manage their diet for their diabetes has been resolved, and it is no longer a nutrition diagnosis. That's just an example. So it is the identification and naming of a specific nutrition problem. It is the missing link in our profession when we started talking about this between assessment and intervention. Because in order to figure out what you're going to do for the patient, you've got to look at that data and come up with a problem you can address, which is the nutrition diagnosis. It's a way to link what is identified in the assessment with what should be expected in the intervention and expected outcomes. So if that patient is ready to change their carbohydrate total amount or choices in carbohydrate in their diabetes, and you provide them with the tools in which to do that, and you go back and monitor it, that's pretty measurable, and over countries or throughout practices, we can look at that and see what interventions work to do that. So again, diagnosis articulates what the problem the dietitian is working on, communicates with the rest of the healthcare team, document for follow-up care, communicate with other dietitians. So in a facility that has several dietitians, or if a patient moves to a different town, different village, and is going to see another dietitian in a different hospital, if we're all using the same language and that information comes to you in that new hospital, you'll know exactly what has been done and what you need to follow up on, rather than just coming to you with a diagnosis of type 1 diabetes. So as I say, it's interrelated. There are 3 general domains within the diagnostic terminology. Intake, and I gave some examples of that. Excessive or inadequate intake compared to the requirements versus actual or estimated. So if you have a child that's growing poorly, and you calculate what they've been eating, and you know how many calories most children that have no medical condition require, and you see that they're meeting 50% of that requirement, you can certainly make a diagnosis of inadequate intake compared to the requirement that either your government has established or the evidence shows for most children. Now there's variation for all of us. There's the clinical, which would be medical or physical conditions that are outside of normal. Diabetes, renal disease, irritable bowel syndrome, on and on. And then there's another category which we've identified as behavioral and environmental, related to the knowledge, attitudes, beliefs, and physical environment, access to food, or food safety. The understanding or acceptance of the need for dietary change for a disease or also for preventative of disease, to try and change a family's food habits, how they eat, how their children eat, make those changes, it really is talking to them about their knowledge, their beliefs, and are they willing to make some changes based on the data that you have and to help their family. Intervention is a specific set of activities and materials used to address the nutrition problem. There may be national education materials. It may be tube feeding or enteral nutrition that they need. It may be a number of other interventions. And the intervention, you need to prioritize what that nutrition problem is. You need to look at what the evidence shows, and then determine with the patient what that outcome you want. For years, and when I first started practicing dietetics, it was pretty top-down. I know what you need, therefore I will tell you exactly what to do, and here's the written information. We now know that doesn't work in behavior change at all. You have to involve the client, the patient, the family, in order to get some agreement what they might be able to do and be successful at. It took us a while to figure that out. And then you will develop what the prescription is, which is what you're going to do. And we have 4 categories of interventions. So the prescription is another one of those words that, at least in the United States, people are having difficulty with. Prescription is medicine, pharmaceutical. All the prescription really is what you have decided that person needs. You're prescribing a plan of care. Could be energy needs, specific foods and nutrients. You know, if someone has gluten intolerance, the prescription is a gluten-free diet. Physical activity can be a prescription. Consistency or form of food, so someone has had a stroke and they cannot swallow, you know, thin liquids because they would aspirate and not do well. It also can just be timing, when they should eat or shouldn't eat based on perhaps a medical condition, timing of medication for nutrient-drug interactions. So how do you select an intervention? Again, there are 4 categories: food and or nutrient delivery. Is it going to be a pattern of eating, foods that they should consume and others that they should probably consume less of? Is it going to be, as again, the form of the food? Nutrition education, how they're going to manage that at home. Counseling is, in our view, is ongoing. It's more than education. It really is using those skills for behavior change. And then coordination of care, which is working with the physician, the nurses, the pharmacists, all the physiotherapy or physical therapists, so that everyone is working in the same goal. So activity and what they can do, what they should eat, the medical management, so we aren't working against one another. So intervention ideally affect the etiology or improve the signs and symptoms. It should make a difference. It may be longer termed than the patient wants or you can identify easy on. And that sometimes is the difficult convincing of other healthcare professionals that nutrition should be the first line. At least in the United States, it's easier to give a drug. Now, there's some data out there that show that patients don't change their diet any better than they take all the pills they're prescribed. But we think it's going to be easier for them, but it is not always. And then you have to monitor and evaluate. What's the appropriate terms? There's appropriate terms for that. And they're around food and nutrient-related history, again, anthropometric, biochemical, comparative standards. It is a repeat of those assessment terms, but you've started at one place and you're looking and see what your intervention did. That's just a repeat. There are some supporting systems in the nutrition care model. Screening and referral systems. So we have pulled out screening, looking at all the data and deciding that a dietitian might need to provide intervention, or at least collecting all the data. The decision we haven't pulled out. Collecting all the data, and in our healthcare system, nurses would do that, or it would be there from the physician, etc. So dietitians may not need to collect the data. What we are trained to do and how we can be the most effective is to look at that data and make those critical judgments. If we have to collect data on 500 patients and there's 2 or 3 of you, you'll never get to the part that will make a difference to the patients. And then outcomes management system, you need to then, and this is where practice-based research perhaps, or a registry kind of system, you need to aggregate of multiple patients versus looking at one patient's progress. So what works in the population of people with type 1 diabetes the best? What's the best intervention we can do? And we need to be able to gather that data amongst many of us, and so we can make sure that we're doing the best we can do and then modifying if there's more information. So, what can you do? you can go back and, or I can, or anybody in the practice of dietetics, can identify the 5 medical diagnoses that you provide care for. So within your system, perhaps someone in your institution where you're working and out in the community can tell you what of the people that come through your system, what's the 5 most common problems that have a nutrition-related component. And then you can look at the literature search and find savings. And in our world, savings is a big deal because everything is fee-for-service. But perhaps saving of time in the hospital, saving of medicines because they have modified their diet, or other savings. And in an electronic health record system, you can do that all electronically. They can pull data, and if you've got a standardized language and everybody's doing it, and behind the scenes, technology-wise, all that data can be pulled for you. Now, many of us don't have quite that sophisticated system, but that would be my dream, that we could all, around the world, look at data. Wouldn't that be exciting? And need to determine cost savings attributed to these outcomes. I think a couple of people this morning talked about it's all about the money, at least in the Western North America and Canada, United States, everybody. It's all about reducing costs because our economy is awful. So in summary, nutrition screening can be done by other dietitians. There's a 4-step nutrition care process: assessment, diagnosis, intervention, monitoring, and evaluation. And then outcomes management is looking the aggregate of several hundreds, thousands of patients and seeing what's happened. Physicians have been doing that with registries for years. You can do great meta-analysis and really see what the best practice would be. And with that, I will turn the program over to Karen. Thank you.